Good morning, everyone. My name is Rebecca Andrews. I am a primary care physician at UConn Health, and I am also the lead physician for our comprehensive pain center that we have. This is the first in a series of 6 talks that we are going to be doing through the Department of Public Health. The goal is to slowly introduce everyone to pain management starting from the beginning, which is why we've entitled today's talk, Restarting from Scratch. We do consults frequently for our providers here at UConn Health, and one of the things that we find is that we have to backtrack to go through a patient's whole history to figure out the actual etiology of pain. And so we're hoping to do some education today on what would help you in your practice. I'm going to let my colleague introduce himself and the rest of the pain team.
Good morning. I'm Dr. Kevin Chamberlin. I'm a clinical pharmacist and proud member of the Connecticut Comprehensive Pain Center here at UConn Health. I, along with another primary care physician, Dr. Jennifer Ozimek, and our addiction psychiatrist, Dr. Sarita Rao, make up the personnel that are on that team. Dr. Jennifer Ozimek was a huge part of putting together this talk. However, the newest addition of her family chose otherwise as to whether or not she'd be able to participate this morning. So we hope to make her proud with our slide work as you see us go through it. So I'm going to turn it over to Dr. Andrews. We're actually going to shut our video off to help with transmission, and we'll get rolling.
So our learning objectives today are basically to have you walk away not as an expert in pain management, although hopefully at the end of all 6 sessions, if you're able to attend them all, you will certainly be on your way. Really what we want to do is improve the way that we assess and manage patients with chronic pain. During these 6 sessions, we're also going to give you some rubrics in communication and how to have difficult conversations, and we'll go over one in detail with each of our presentations. So why is chronic pain so frustrating? Well, one, I think we're in the primary care office and we're doing a lot of work all at the same time, and then we're trying to work on chronic pain, which really doesn't have a resolution. It has a way to manage it. The other reason is it is one of the most common chronic conditions that we see. If you look at heart disease, cancer, and diabetes combined, there are more patients with chronic pain, and it's costly. Over $600 billion annually are spent on treating chronic pain. Not all pain is bad. When we think of acute pain, it is both protective and adaptive. The problem with chronic pain is that it is actually a maladaptive process. One of the things that we like to highlight is not every patient with chronic pain is the same. And unfortunately, there's no perfect algorithm that you can apply to each individual patient and have it carry through for success. Patients bring with them a host of resources or a lack of resources, cultural beliefs. They might have different physical or psychological components to their pain, but so do we as clinicians. We bring in some implicit bias, and although we're not going to do an exercise that Dr. Chamberlin and I like to start this with, I am going to walk you through 2 different patients, and I would just ask that you think about those patients and see in your own head, in whatever space you're in right now, work or home, if you feel differently about them. So patient A is a 35-year-old male construction worker who hurt his back on the job. He's been out of work now 6 to 8 weeks. He has persistent pain and disability. You've sent him to physical therapy. You've tried anti-inflammatories, some Tylenol dosed correctly, and he still has pain and he's looking for something to treat his pain. So just take a second and think about the feelings and the emotions that you have thinking about trying to treat this person with their low back pain. And now I'm going to present patient 2. This is a woman who's 27 years old. She's sitting in your examining room with her 3-year-old toddler. She's a breast cancer survivor who is status post lumpectomy and radiation. She's on a very similar medication regimen, and she's here complaining of persistent pain and looking for something stronger to treat it. And so I would ask you again to take a second, maybe write down some notes and think about how you might feel differently about those two patients, and just acknowledge the fact that we do have implicit bias in how we approach pain for individual patients. I really want to highlight the lack of education around chronic pain, because this is what leaves us, once we're out in the world seeing our own patients, feeling kind of overwhelmed with chronic pain. 30% of US and Canadian medical schools really don't spend even 10 or 15 hours on chronic pain, and it's not packaged nicely together. It's sort of piecemeal throughout the education curriculum. A study looking at all physicians in North America found that only 34% of them felt comfortable or skilled at managing pain. So now you have your patient in the office and you're thinking of these two patients I discussed earlier. How do you identify how to treat them? You kind of have to check your own bias at the door, which is why we started with that. But there are a lot of things going on in a visit. And so we would like to advocate for a patient-centered, disease-driven approach to how we deal with their care. I'm going to highlight the bottom part of this slide next, but what we're really looking for is a pain-appropriate history and physical that can take some time to do. And the real key is establishing a therapeutic relationship that's going to help you work with your patient and get their buy-in for the treatment plan. So ideally, you set the agenda. You're looking to go through the 7 parameters of pain. Even if you've done it before, maybe bring up an old note and make sure that those factors still exist. You want to look into what additional histories does this patient have? Has there been physical trauma, psychological trauma? Is there underlying substance use? What kind of medical problems do they have that might be compiling it? And are there social supports that they're either lacking or that we can utilize? What have they tried, both pharmacological and non-pharmacological, but with details? Why didn't it work? What was the intolerance? What was the dose? And most importantly, what are the functional limitations for this patient? What is it that the disease prevents? You really want to hear the patient's story, because that will help you focus on a functional goal, or what we call SMART goals, so that both of you have an end goal that's not getting rid of the pain, but really making their life more functional, and always using collaborative language and empathy for assistance. I'll put up this slide just for a second. This is really as a reminder that there is a physiological basis for pain that involve neurotransmitters, ascending and descending pathways, and that it starts with tissue injury or trauma. So I know in medical school, for me, we learned about different types of pain, but we know a little bit more than we knew before now. Ideally, you can identify this in your patient and treat accordingly. There are a type of pain called nociplastic pain. So this is your fibromyalgia, headache, interstitial cystitis. There's nociceptive pain. These are more of your rheumatoid or osteoarthritis, tendinitis. You have classic neuropathic pain, such as a spinal cord injury. But what we also now know are there potential mixed states. Even osteoarthritis is now known to have a neuropathic component to it. And this is what makes treating pain a little more challenging once it's chronic. We also know from the literature that the biopsychosocial model of treating pain is hugely important. We can't ignore the other factors that come into play, not only to the degree of pain experience, but also a patient's ability to manage, function, and respond to that pain. And as the evidence comes forward, we actually realize how much we don't know. So if you look on the left side, what we used to know was that chronic pain and depression come together in a pain-depression dyad, somewhere around 50% of the time. Both of these pathways involve serotonin and norepinephrine and their pathophysiology. But recent data, which is highlighted on the right side, is that use of long-term opioids trying to treat such pain can actually lead to depression. And I think this highlights just how complex chronic pain is. So before I turn it over to my colleague, I'm going to show you one last slide. Using shared decision-making can actually help combat that feeling of being overwhelmed trying to come up with a treatment plan. The idea is that it doesn't rest solely on your shoulders, but that you and your patient are going to work together to pick the right treatment based on type of pain, their preference, be it because of culture or how many times a day they want to take a medicine, and that you can use that to identify non-pharmacologic and pharmacologic treatments that might work best for them.
Thank you, Dr. Andrews. While we can't spend a ton of time on the lower portion of the previous slide that's actually zoomed in on here, we show it to remind us of the multiple modalities that can be used together to optimize pain outcomes. So on the left is the stuff that we too often forget to utilize or move past too quickly, and we'll call it the non-pharmacological interventions. It's really helpful, and it can help minimize the use of the items that are on the right, the kind of traditional pharmacologic entities. The literature that exists for chronic pain is limited, and especially with regard to what therapeutic entity works, be it this week or how long even the effects last. So the options are based on history, physical type of pain, patient preference, strength of evidence, and just because the patient may have failed a therapy previously or even a non-pharmacologic intervention previously, it doesn't preclude them from actually revisiting it again. There's recent evidence that suggests that shows a retrial of some of these meds, even at the same dose and in the same combinations, had better outcomes the second time around. It could very well have been a wrong dose or a wrong duration, or even patient poor adherence, or just not the right time for that particular intervention. And again, there's good evidence for revisiting and optimizing that can have positive effects. And frankly, let's talk about the elephant in the room. Just because you start opioids, it doesn't mean that you need to continue them. If they're not meeting goals, or even if they are, consider de-escalation. If they're having side effects, consider stopping. Readdress the risk-benefit opportunities at each visit. Consistency is key. Consistency visit to visit with the same patient, but also between patients on your panel.
So before we go on to the next section, just a quick recap. You really want to take a huge detailed history about the pain characteristics, treatments, functional limitations, etc. When crafting your plan, you want to say to your patient and in your head, what is it? What is the main thing that the pain is preventing them from being able to do? That's going to focus you for your functional goal. The goal is not to be pain-free, and setting that at the agenda and as a bar right in the beginning for the patient helps you get on the same page. But you're trying to help them regain part of their quality of life and their identity. The right side of this just talks about really using patient-centered interviewing, and we'll make a plea several times through this talk. The use of collaborative language and empathy can help you be successful.
So we should really talk about this in two realms, acute and chronic pain. Comparing the two, think about flipping your treatment algorithm. Acute pain focuses on regional techniques and abating the pain. For chronic pain, though, non-pharmacologic intervention is really the base of your regimen. So focus on functional outcomes. Chronic pain treatment is focused, yes, on pain reduction, but more on quality of life. So the red box in the upper right-hand corner shows that there's limited data for chronic pain. And so we are constantly adjusting and pivoting the mindset as more data become available. I think it's really important to note the words in red: restore function, reduce pain, improve quality of life, and cultivate well-being. We touched a tiny bit on treatment, but let's go a little further into specifics. So we're going to start with the elephant in the room, the opioids. And there exists a bunch of myths surrounding opioid use. It goes without saying that if you do use them, to start low and go slow, and as I like to say, sometimes say no, and make it clear that it's only a trial at first. We have an upcoming talk that will delve further into extensive risk-benefit assessment in a future session. Two common myths about opioids are that one, they are uniquely powerful, and two, that they are particularly effective for acute pain. And yet, in reality, little evidence supports any superiority or advantage over non-opioid therapies. Similarly, underprescribing further dispels the myth of any advantage of opioids. While not forbidden for use, opioids rarely offer advantages for relief without side effects in the rare patients that fail to find relief otherwise. The left side of your screen should look familiar. It's actually an updated iteration of the well-known WHO analgesic stepladder, but with greater emphasis and now a fourth step on non-pharmacologic therapies throughout the pain management continuum. Remember, as you step up, combine your pharmacologic therapies of choice with non-pharmacologic things like ice, heat, acupuncture, physical therapy, and don't forget to step down therapy. The right side of the chart actually further illustrates the ideals that separate acute pain from chronic pain and illustrates the strength of non-pharmacologic interventions, things like massage, spinal manipulation, exercise therapy, and how these lead to improved outcomes as versus acute pain. Acute pain focuses more on those self-care and pharmacologic therapy interventions.
So again, just to put this in perspective for you, chronic pain is not only common, but it is complex. There are a host of physical, cultural, psychological comorbidities and just factors that all kind of roll up into one. We need to be aware of the challenges in treatment, whether it's disparities in healthcare, our own implicit bias, challenges in getting some of the non-pharmacological but mainstay treatments covered by insurance, the cost of team-based care, which is really better for chronic pain, but can be exorbitant and has to be supported by organizations and also insurers and payers. And of course, the fact that the majority of chronic pain visits, we know they occur during episodes of other chronic conditions, and therefore you have competing priorities that make it challenging to really focus on the chronic pain. So why are difficult conversations avoided? I don't know that this slide needs that much explanation, but I can tell you that I struggled this with one of my children last night. We don't like making the people we love and care about feel poorly, and that feeling of conflict inside is sometimes difficult to swallow. With our patients, we went into medicine to serve and to make people better. And so sometimes saying no or not being able to quote unquote fix their problem really is psychologically hard on us. So that in the literature, there is a term called frustrated success. It's when you can't get that patient in your office to lose weight and you're both doing everything right and it's still not successful. That happens a lot in chronic pain, and it can sort of escalate the emotions. And so these conversations tend to be a little bit more challenging than others. But I don't want you to feel like when you're in the room that the challenging patient encounter is a bad thing. Conflict does come to resolution. It is a means to get there. And there are patient characteristics that we know are associated with patients being challenging. And so just know what they are so that when you walk in the room, you can sort of mentally prepare for that. And it's a lot of the patients you expect. They have more conditions, more challenges, greater functional impairment, more symptoms, etc. Unfortunately, as clinicians, we also have things that make us more likely to view an encounter as challenging. And it has a lot to do with our years and out of training, how high we perceive our workload to be, how happy we are with our job, and this, how good are we at communication skills? So hopefully today will help us get there. Again, I would like to make a plea for the use of empathy and compassion, not only for our patients, but also for ourselves. We're going to run through quickly some tools today to work on discussing and working through these negative emotions. But before we discuss it, it's just a reminder that it's okay if you feel drained after a challenging encounter. You can walk out of the room if you've used empathy and compassion, knowing that you did the best thing for the patient.
At the root is developing good rapport. open communications, and utilizing shared decision-making. There are techniques we're going to touch on today, but go over it in greater detail in another session in the future. Actually, I think it's the next one, believe it or not. You can review on your own, or you can certainly come back for more. These are all shown to overcome challenging communications. With chronic pain, it is a constant assessment and reassessment of meeting goals and deciding if we need to change therapies. We can all agree that pain is a condition that we can't see and only the patient can feel. There is this abundant tension that escalates over time. And from time to time, the patients are constantly questioning trust, and clinicians are always seeking to verify. As these tensions escalate, consider these communication strategies to put into practice. The first that we'll discuss is actually the one that Dr. Andrews and myself have homegrown and published on. And we use it to teach medical and pharmacy residents the stages of acceptance in a way that's modified from the Kubler-Ross well-known stages of grief. In so doing, it helps the clinician keep grief as the forefront of framework to this discussion modality. The second, or the NURSE, is a framework that utilizes the acronym for name, understand, respect, and support. So rename the feeling the patient stated, like you're worried, or name the emotion you are reading, like you seem worried. For understand, think, I can see how you could be feeling this way. Many people who have backaches are worried that it could be due to something serious. Respect, this is a lot to go through, or think, you've really been through a lot, or I appreciate how you have hung in there with all this. And finally, support, let's see what we can do together to get to the bottom of this, or I want to support you in any way that I can. For the third, it's the ATA, or the ask, tell, ask. And this skill is a good methodology for making the individual feel validated by hearing the patient's story. Another to consider is Adobe. And Adobe is a great framework that you can switch into when the situation is really heating up, when emotions are running high. It's really all about trying to drill down into what is the foundational cause of the tension so that you can diffuse it and set boundaries. The 5 steps is a framework for any intervention or behavior change, things from quitting smoking to weight loss or even changing medications. In this setting, where some of the conversations may become emotionally charged with in particular to pain management, the Wasan and colleagues version can be particularly effective. But if you like it, you can certainly use it at any point in a potentially difficult conversation. Think about acknowledging the problem, allowing the patient to vent, agreeing on what the problem is, affirming what can be done, and assuring follow-through.
I'm going to talk about this 6th technique in a little more detail. Like I said at the beginning, we'll go into each one of these with each of the talks that we discuss, but I agree with Dr. Chamberlin. The next presentation we do is all about communication. So if you want to hear more about these, join on. These are better to practice than just to tell you about, but to sort of wet your whistle and get an idea of what they are, we'll start with this one. So there's a book, Nonviolent Communication. It's an easy read if you want to pick it up. It really has 3 components, and I'd like you to note that the first is self-empathy, to understand that this is hard, and the last is honest self-expression. I think so often when we're in the room with a patient, we're trying to meet their needs and desires, but with pain management, sometimes those medications or interventions carry a risk with them, so we really need to highlight honest communication and detailing that so that we can have a good discussion and make the right decisions. There's essentially 4 steps to nonviolent communication. You want to first observe objectively. What are the facts? Use it as a mutual talking point. So as an example, I noticed you were raising my voice at me earlier. It's an observation that is stated without judgment. State how you feel from the observation. It upsets me that you raised your voice at me. And then you want to connect with a need. So in this setting, we're talking about connecting with a need for our patients, but you can use this at home on your spouses, your significant others, or your children if you like. So an example would be, Were you angry that I was unable to call you yesterday? And then the last is making a request. So say you're dealing with a colleague who's always late to work, so you're managing some of their duties or answering the nurse's questions. Something that you could say is, so what can we do about your attendance? What is getting in the way? How can I help you? How can I help you be more successful at work? Again, non-judgmental language. So just to walk you through a scene, my kids are not here with me today, which is great, so they don't need to know that they're an example. But I had a high school senior last year, and I have a middle schooler, and I would come home tired every day after work, just sort of sneakers and their book bags and maybe a few musical instruments just literally dropped right outside the door where I come in. And so I like to use my own warm opener when I use nonviolent communication. So I would say something like, hey guys, can we talk for a minute before I get started on dinner? Because inadvertently, while I'm tripping over their articles, they're asking me when dinner is going to be. Then a non-judgmental observation would be something like, I've noticed when I come home after work, your school bags are all right in front of the door. And my statement of feeling would be, I'm rushing home. I'm really excited to see you and get dinner started so we can sit down and eat together. But I feel irritable because I need to move everything out of the way before I can do that. A statement of need would say, you know, I need to transition from work to home so I can enjoy my time. But I also know that you need to relax after school and probably don't want to put everything away the second you walk in. And then you follow up with the request, which should really be specific and actionable to fix the problem. So do you think we can find a space that's inconvenient for your belongings, but also out of my way when I come home? So how would this translate to work? So I just chose a particular example for me. I have a patient who is really worried about pancreatic cancer because his mom has passed from that. So my warm opener, as he's asking me about, you know, pancreatic cancer screening would be, I really appreciate you bringing your concern to me today. My observation would be, I can hear how concerned and worried you are. It sounds like you are really distressed about this. However, part of my job is to make sure that I'm ordering tests that will actually get an answer to your question. And currently there's no test I can do to screen for that is approved that doesn't carry a greater risk. When you use your feeling statements, you can do your feeling in their feelings. So you can say, I'm uncomfortable ordering this test because we're not going to get the answer we're looking for. But I also understand that just waiting is making you anxious. The test might actually find something abnormal that we wouldn't have had to worry about that is not going to impact your life at all. But once you see that with the test, you might have more anxiety and you just don't realize that. So a statement of need would be, I need to consider all of these risks and benefits to make a decision and chart a safe course. And then my request would be, what if we both keep our eyes on the news? If either of us sees that there's an approved new test for pancreatic cancer screening, then we will look into it together. And that's an example of how to use nonviolent communication, both at home, where you can practice, and at work. So just a couple of tips for success that we have sort of culled over time when we teach these skill sets. Just remove the tension. Stop worrying about if the pain is real. Pain is a perception, so support the patient in their pain. Know that you actually do have implicit bias, whether you recognize it or not. So any emotions you have, your job is to maintain calm and really manage those on your own internally. We focus on facts, behaviors, not character, and we do that by using non-judgmental collaborative language. But there should always be respectful communication. And if this is one of those heated conversations, consistency, 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 but think about safety. And ideally, you keep them in your care. Many patients with chronic pain transfer providers multiple times before they find someone they jive with. So really try to keep them in your care for their benefit. This slide is just to give you an idea that it's a 1 to 2 time period from denial to acceptance for any of the changes any of us go through. So this is not a one and done treatment algorithm.
Here at UConn Health, we actually created an opioid toolkit, really for a pain management toolkit, but it was created by our opioid task force. And we have a bunch of best practices, and we'll dive into this in greater detail in the future. But we're going to actually go through one of our actual patients. It's been simplified for the purpose of this talk, and obviously the name's been changed. So let's meet Ralph. Ralph's a 57-year-old male with a past medical history of morbid obesity, gout, hypertension, seizure disorder on valproic acid, chronic low back pain, and OA of the knee. He had a spinal lumbar decompression of L3, 4, and 5 with a right L4, L5 synovial cystectomy in June of 2009. His current regimen is on the screen, but it includes a morphine milligram equivalence of 15, an ACE inhibitor, his Depakote, and allopurinol for gout. For pain-specific items, he had initially been started on hydrocodone in November of 2013 by his neurosurgeon for back surgery, or for back pain rather. And it was unclear if he was taking this prior to surgery in 2009 or what treatments were actually tried between 2009 and 2013. In 2016, his PCP took over his opioid prescriptions, and this is pretty typical that the PCP would be asked.
So I just want to pause and reflect here because this is one of the triggers that I think we have for new patients. It's the inherited treatment plan. This is very typical in primary care, but I'm sure in other specialties as well, where you're kind of stuck in a spot of trying to decide, do you switch therapies midstream? You know, is it your responsibility to continue the medications? You don't know how this treatment plan evolved. And I would argue that it's our responsibility when this happens to clarify the cause of pain, look into previous workup and treatment. You can't always get all the old files, but at least having some idea that it had been worked up before you went down this path. I can tell you there's been a number of times we've identified a true cause of pain and been able to switch therapies for better results. When you inherit a patient, though, I do want to be 100% honest. You also inherit their psychological commitment to the plan that they're on, and that's what makes changing treatments with new patients a little bit more of a challenge.
What can be really helpful is putting together the timeline of treatment course. And so remember, in November of 2013, he had been started on hydrocodone. And now in February of 2019, he's using 1 or 2 tablets per day of this hydrocodone due to the worsening pain exacerbated by his job. Of note, he's also gained 18 pounds. So should we think about tolerance, addiction, opioid misuse? And it's probably time to revisit the goals of treatment.
So we talked about the biopsychosocial model earlier, and this is a great example. So Ralph feels he was fired in 2009 specifically for his sciatica. That wraps into how he feels about his pain. Then he was unemployed for 5 years. Now he's driving a truck part-time, which is a new job. We know he's divorced, so we know that he doesn't have as large a support network at home as if he was married, but we also know he has religious beliefs, and we can leverage those for ideas on how to use cognitive behavioral therapy for his pain, etc. So this is typical of what we see when we do consults. You know, we have some information from his BMI. The musculoskeletal exam is pretty benign, almost templated, so to speak. The gait wasn't assessed. There's information about the skin, which is great because it helps us determine if there are more systemic causes. And then the neurologic exam is also listed. You have to be careful with physical exam templates. I think we all use them to make our jobs go faster, but we really need to be specific with descriptions and limitations so that when we look back in our notes, we can figure out just how much their pain is affecting their function.
Continuing, now you see some of the labs specific to pain. So his vitamin D was low, his A1C was 5.3, and his TSH was within normal limits. So could it be cause or mitigation? But this is definitely a thing to review.
And I would just add that there are certain laboratory assessments that are helpful with chronic pain, but not necessarily on a regular basis. We try to see if those have been looked into. So for Ralph, what's contributing to his low back pain? Not to make you feel like you're a resident again, but here's a differential or at least a start of one. He is morbidly obese. He probably has some muscular overuse after not working for 5 years and now driving a truck. He's sitting a lot, which could cause a quadratus lumborum overuse syndrome or strain. He could have degenerative disc disease, osteoarthritis could be rolling into it. And another question I like to ask is, yes, he has chronic low back pain, but is there an acute injury on top of that? And just to separate those out and piece them together. So we really want to do our best to treat Ralph. And in order to do that, I have to figure out what is the most likely underlying etiology so I can tailor that modality. My treatment of fibromyalgia pain and osteoarthritis pain are not going to be the same. If we were doing a consult for the PCP for Ralph, we might say we really need the musculoskeletal exam to be more detailed. Where is the back pain? What are the limitations? I need to see what his gait is like. Can he lift his knees up like he should be? Is he using a shuffling gait, etc.? What about his psychiatric history? Is there a prior history of depression? He had a low vitamin D, so we definitely want to replace that. We know that vitamin D has a role in chronic pain. He's been on Depakote. Do we do a DEXA scan to look for osteoporosis? There is bone pain that can come with osteoporosis in the literature. And then his weight gain. Let's refer him to a weight loss clinic to try and help him lose some weight and improve the pressure that's on his back and his knees. So some beginning thoughts. Ralph may have some poor coping skills for managing pain, just given that he has to deal with psychological downfall from being unemployed and what he perceives as being fired without support systems at home. He would really benefit from chronic pain visits. So chronic pain is a chronic disease. We see our diabetics every 3 to 6 months. We should also see and assess chronic pain every 3 months. He's been on the same opioid regimen for years. He's tolerant, and the likelihood that he's getting any pain relief is actually pretty limited, but he still, as I've said before, has a strong psychological attachment. The belief system that patients carry that this medication regimen they're on is actually strong and working for them without the same understanding of what happens with tolerance is really a disservice to patients, so we have to educate them on that. And he would really probably benefit from a reassessment, consideration of alternative therapies to minimize risk. At a minimum, taper him off the opioids, leave him opioid free for several weeks to several months, and then see if other treatments work and actually work to improve his pain in a different manner with lower risk. The pain depression dyad is real. 50% of patients have these in coexistence. And as I said earlier, whether it's because the depression came with the chronic pain or our treatments for chronic pain induced depression is arguable. There is a physiological reason for this. The serotonin, the norepi systems actually come into play for both of them. So assessment, diagnosis, and management can be extremely challenging. And I would really like to highlight treating both yields improved results. And if you don't think of it even just as pain, both of these impact cognitive abilities. So getting a person back to function, we really do have to treat both.
And sometimes we can actually co-treat, so with a single entity. So evidence exists that duloxetine can be helpful with both depression. We know it can be helpful with depression, but also anxiety rather, and also pain. What's key is that it's actually dose specific. And so starting at 30, but targeting 60 is really optimal. There's not a lot of data that supports going above 60 milligrams without worsening side effects. From a non-pharmacologic standpoint, let's start there. The treatments are no longer considered alternative. They're mainstays. Think back to the WHO stepladder 4. So integrate mindful meditation and yoga acupuncture. Osteoarthritis really can benefit greatly from non-pharmacologic intervention, not just with education, but also exercise and weight loss. A German randomized controlled trial showed that acupuncture was more effective than none in migraine-specific related pain. Alone or adjunct, acupuncture provides short-term improvements in pain and function for chronic low back pain. And yes, obviously, more randomized controlled studies are needed for added validity. But the basics, again, I refer you back to this modified WHO analgesic stepladder. Start with acetaminophen and then add an NSAID if there's no contraindication. Acetaminophen needs to be scheduled and you need to hit a dose. So it's got to be north of 650 milligrams per dose and really targeting that 975 to 1,000 milligrams scheduled. For NSAIDs, just because they fail one doesn't mean they failed the class. There's actually 11 different subclasses of NSAIDs to consider and rotate through. Examples would be how meloxicam and celecoxib and diclofenac are actually all different classes and different from ibuprofen or even naproxen. So recommended dosing examples are actually illustrated on your screen, but make sure that you target getting to them for greatest effect. Further, there is a space trial that's often quoted from JAMA in 2018, and it was a 12-month randomized study that looked at patients in the VA, but specifically with chronic back pain or hip or knee osteoarthritis, and they compared opioids versus non-opioids. What they found really with the take-home point was that opioids were not superior for improving pain-related function over 12 months. And this is a study that's often quoted and further supports the idea that really acetaminophen and NSAIDs can be just as effective, if not more effective, than opioid therapy. For this patient, for our patient and Ralph, who may have demonstrated some osteoporotic bone pain, consider bisphosphonate therapy. It's been shown to reduce bone pain. You can consider calcitonin nasal spray. I know, a blast from the past almost, but it's an unlabeled use of calcitonin for osteoporosis, specific with vertebral fracture, metastatic bone pain, trigeminal neuralgia, and phantom limb pain. But there's increased evidence of its analgesic effect and as quickly as the second week of treatment. And the dose is illustrated here. Muscle relaxants can have a benefit, but really should only be used short term. This is a soapbox of mine that I won't get on, but evidence for one of them, like cyclobenzaprine, specifically suggests that there's loss of therapeutic effect and an increase in side effect with use beyond about 10 to 14 days. But what we do know is that there's about 50% loss of analgesic spasmodic efficacy for each day beyond the 5th day of use. And if there's no spasm, then there's really no benefit. Long-term opioid therapy, or patients treated with long-term opioid therapy regimens, do develop tolerance, and it's a natural component of opioid use. And then as they develop tolerance, the longer the patient's on it, it's really likely not contributing to pain relief. The risks are obvious and we all know them, but think hyperalgesia, think gonadal suppression, urinary retention, chronic opioid associated abdominal pain, etc. And so here, that's where we start thinking about the benefits of tapering, which can reduce the tolerance and help identify a concrete functional goal, such as working that 4-hour day, and we treat to function. Neuropathic considerations, again, pharmacotherapy, but you need to hit these minimum treatment doses, especially with the gabapentinoids. So think gabapentin or Neurontin, you need to hit that 1,800 milligram total daily dose. We talked about SNRIs. We talked about the benefits and the importance of non-pharmacologic therapy, but with specific to neuropathy, think TENS unit or some sort of stimulation treatment with physical therapy.
I just wanted to comment as far as the workup goes. We know that being hypothyroid or low B12 can actually add to a patient's pain. Looking for systemic causes. So this is an example of some of the workup that we'll do, looking for HIV, SED rates, SPEP and UPEP. If you're really trying to determine etiology and you're unsure, consider something like an EMG. Again, these aren't necessary for every patient, just giving you some idea of what to think about. Since Dr. Chamberlin got off his soapbox about using muscle relaxants, I will be quick here because I've mentioned this multiple times. I think I just really want to highlight that cognitive behavioral therapy really aids in the patient's ability to accept that they have chronic pain and then move into management. And I think support groups are something we forget about, but they really do help. They can decrease the feeling of isolation, help the patient learn coping mechanisms, and most important, they learn those mechanisms from peers as well as the facilitator. So we've talked a lot about functional goals. You should use SMART goals if you're capable, and it's really easy to learn how to do them. There's lots of examples online. They're called SMART goals because they're supposed to be specific, measurable, attainable, realistic, and time-based. So for example, we know that obesity adds to osteoarthritis pain. So maybe for Ralph, what we would do is say he wants to lose weight to help with his pain. His measurable goal is 2 pounds a week, but to make it attainable, we're talking just 15 pounds to start. Realistically, we want to do that over 3 to 4 months, and then time-based. So 4 pounds in the first month, and then the next 4 months to do it. Again, as we've mentioned before, there are high-risk medications used in treating chronic pain. And so if someone has not obtained their functional goal with the use of that medicine, we should consider stopping it.
I briefly mentioned that we had developed an opioid toolkit here at UConn Health, and again, we'll dive into that further in a future talk, but the framework is kind of bulleted here. So partnering with our patients, the utilization of medication agreements with specific functional goals, the attempts to reduce stigma and chronic disease. Remember that, as Dr. Andrews alluded to, treat pain as a chronic disease, just as you would diabetes. And so regular visits and follow-up. But also know when to stop, assess risk. Have we attained that functional goal and now we need to step down? Trust but verify, the use of urinary toxicology. And remember, we do have some laws that regulate how often we are supposed to verify prescriptions within the PMP.
So I just want to give you an example of some of the things that we've written on patients. All the identifying data is removed. This is an example of what we put at the bottom of a note for someone with chronic pain who actually is treated with opioids. Do they have a medication agreement? Does it need to be updated? Check with PMP, et cetera, and then naloxone prescription, which some patients are resistant to. This is actually from a patient with phantom limb pain, and I just wanted to put it up just to give you a second to look it over. This is an example of how you can use the literature to back treatment for a specific diagnosis. None of us were experts in phantom limb pain, and I do realize that we work in a multidisciplinary team, but when you tailor the treatment to the disease, you are still within evidence-based guidelines, which helps you and the patient know that the medications are worth trying. Again, not to leave it off the table, substance use disorders are often commingled with chronic pain, and our goal is really to destigmatize them and to offer treatment just as we would do for anxiety, low back pain, etc. Sometimes patients are accepting and sometimes they're not, but it is an example of another chronic illness that we shouldn't let go untreated. This third or fourth example is just someone who's improved over time. And here you can see her functional goal was choosing to live independently. And what that meant for her included needing to improve body strength. I just want you to look at the bolded titles here on this patient consult, just to highlight that many pain syndromes come commingled. Migraine, headaches, fibromyalgia, seizure disorder, substance use disorder, past history of counseling use for mental health conditions, all of that really made this patient a little more complex. And then lastly, I just wanted to highlight that recommendations are not always pharmacologic. So these are things that maybe the patient's looking for, but maybe we have other options such as bariatric surgery or doing a vascular workup that could actually help treat their pain on a more permanent manner.
So to wrap up, 80% of the story to identify the pain etiology will be from the history. So combine that with imaging and labs as you need, but remember the history is very important. Qualify that functional goal. Being pain-free is really not a realistic option for most chronic pain patients. Highlight the non-pharmacologic options, even as you step up in pharmacologic intensity, but also don't forget to step down. Remember that frustration can exist for the patient and the clinician, so consider employing empathetic communication rubrics like we discussed to work through these challenging conversations. We really want to say a great big thanks to the Connecticut Department of Public Health, who made this conference possible through the grant funding from the Overdose Data to Action. We look forward to having you and more of your colleagues at the remainder of our seminars over the next year and a half.
I just wanted to remind everyone that it has been recorded. So if you missed the beginning or you want to go over any of the slides or components again, you'll be able to access it. And I think we're going to try to open it up for any questions since we finished fairly on time. There is a Q&A that you can type your questions into on the right-hand side under the participants.
We are working, figuring out how the questions are. Hold on. Q&A, there it is. Are there pain psych resources locally? So actually, I think I saw
I think Dr. Rao
is
joined
on.
us.
I'm actually going to turf it to her.
Hi everyone. Pain psychiatry, pain psychology resources are in some amount of short supply. However, that's the bad news. But the good news is that pretty much like any therapist who treats depression, anxiety, and has some experience with cognitive behavioral therapy or acceptance and commitment therapy would be able to help a patient with chronic pain significantly with accepting the change in their life, with treating comorbid depression or anxiety, even if it's stemming directly from the pain. So one easy way to find a therapist for a patient is to go to psychologytoday.com. You can do that for like 5 minutes in the office if possible, or have your MA do it with them. It doesn't require any kind of psychiatry expertise. You just go on psychologytoday.com, click on find a therapist, and then put in the patient's town or zip code, and then help them to look around. So in these lists, you will find psychologists, master's level, social workers, licensed marriage and family therapists, and it'll say what insurance they take and what are their areas of expertise. So if you have somebody who has some experience in dual diagnosis, as in substance use disorders, or in depression, anxiety, they would be able to help your patient to a significant extent. And it does not require a visit to a psychiatrist or a psychologist. Master's level therapists who are not in short supply at all would be very much able to help your patients. So I hope that's helpful.
Thank you, Dr. Rao. So again, if you have a question or a comment, I think there's a Q&A option in the participants window that we have to utilize. There's another question. How do you start a TENS unit, Dr. Andrews?
It's me. Hi. Okay. So I love TENS units. The first thing I would say is there are two utilizations that you can do with a TENS unit. So the first is just to get alleviation of the pain and the sensation that they're having now. So they can put the, usually there's 2 pads for electrodes, some have up to 4 on the location. So let's say we're dealing with left-sided sciatica. Maybe they put one on the posterior buttock area and then one on the lateral side of the thigh, or you could do like thigh and lower calf. And on the TENS unit, there are usually 2 knobs, one which is the program, so how it feels. Is it zapping constantly? So you're gonna have to deal with my noises, but like zzz, or is it intermittent? Zzz, 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 zzz. Is it a sine wave? So it builds and crescendos and decrescendos. They can pick whatever one works for them. And the other knob is intensity. So think of it like 0 to 10. And they're really just trying to get it high enough to override the sensation from the nerve. and that they can do as many hours of the day that they want. But during the day, they should also be sure to use it in another manner, at least twice for 20 minutes a day, to try and re-educate the nerve. So what you want them to do is, again, they can use whatever pattern feels okay for them, but they need to turn it up high enough to get a fasciculation in that muscle. So just a little twitch, not like a huge shock, but just a little twitch. And what it is doing is it is working with the nerve and the muscle to reset sensation and physiologic function and sort of curtail that signal of chronic pain that's going back to the brain. Because remember, chronic pain is both the physiologic response, but then the pathophysiologic response of long term. And sometimes the nerve is misinterpreting signals or stimuli as pain when it is just normal. And we're trying to reset that. Okay, so another question is it a simple script? Yes, sometimes, and actually we've come a long way. Some insurances will pay for it. You know, the patient actually can call their insurance to find out about it. Sometimes there's paperwork that they can then bring into you. You can get them on Amazon. You can get them at the pharmacy over the counter. They do differ in effectiveness, and you can read about those. Okay, next question. Do we have a pain medicine specialist for invasive surgical nerve blocks or therapy? No, we do. So I do trigger point and knee injections. We're part of UConn Health, so we do have a physiatrist who's part of our spine team who can do epidural injections. And then they use nerve blocks prior to surgery as well. Do we have acupuncture? We did. So acupuncture, when we were talking about the cost of chronic pain, acupuncture is one of those things that we're really pushing insurers to catch up on. I think Medicaid, Connecticut State Medicaid is paying for our acupuncture for low back pain and knee osteoarthritis, but it's constantly changing. So I'm always looking to see. And then Cigna, Blue Cross, Anthem Blue Cross pay sometimes for acupuncture depending on the indication. Easiest indication to get it paid for is actually migraines. Trying to think, there are you can use outlying acupuncture centers. I know Hartford Hospital is working to develop an acupuncture program. It's a little bit harder than it sounds just because of reimbursement. I think we're almost at 8 o'clock. Are there any other questions? Hearing none. Okay, so we're going to stop recording. If you do come up with other questions and you want to reach out to us, please feel free to do so. Remember, there's going to be about 6 of these, all touching on different topics over the course of the next 18 months. Thank you all very much for coming. Again, we're sorry Dr. Ozimek's baby had other plans in mind, and thank you to the Connecticut DPH.